Hello, everybody. My name is Daniel Weygl. I'm chief of the pediatric orthopedic department at our hospital at the Schneider Children's Medical Center. I wish to thank the organizers for giving us this opportunity to share our experience with Duchenne muscular dystrophy. So, of course, I will talk of the orthopedic aspects of the disease. I will speak of the typical appearance of the child while coming to the orthopedic office, uh, concentrate on the physical findings, physical examination findings that we see in these patients, and of course speak of the orthopedic management and concentrate on lower extremities, spine, and fractures management. So the orthopedic surgeon might be the first doctor to encounter these patients. He might be the first one to see these patients that will be brought by their parents to the orthopedic office. So we should be aware of this diagnosis and think of every child who walks on his toes with an equinus gait without any obvious explanation for that, with normal birth history and so on, as somebody that might have this kind of muscular dystrophy. The parents will usually tell about very insidious onset of muscle weakness. So the typical patient will be at the preschool age, 3 to 6 years old. The chief complaint of the parents, as I mentioned, will be very mild muscle weakness, difficulty in climbing stairs, very slight delay in physical milestones, at a very slight delay in age walking, and sometimes very mild clumsiness might also be among their complaints. Now, there is a typical appearance of these children, typical standing, because the involvement of the muscles is very symmetrical, and the proximal muscles, as you know, will be more affected at the early stages than the distal muscles. We will see very often, because of weakness of the hip extensors and early anterior pelvic tilt stance, with resultant hyperlordosis of the lumbar spine. This anterior pelvic tilt will cause the ground reaction force to go forward in front of the knees, and by that causing hyperextension of the knees, because again the ground reaction force moves forward to the knees. And this might also be an expression of weakness of the quadriceps, as this hyperextension is based on the posterior knee ligaments that support the knee with no significant effort of the muscles. Of course, the child will sometimes walk on his toes. This might be a very early sign of the dystrophy, of the muscular dystrophy, and this is again not only because of the obvious contracture of the gastrosoleus, but also a way, as I mentioned before, walking with the ground reaction force in front of the ankle, causing the ankle equinus that supports the knee into extension. So the equinus gait is part of the hyperextension of the knee, secondary to muscle weakness. So with time, we will see these children walk first with mild hyperlordosis and anterior pelvic tilt. This will usually be accentuated with time. The lordosis will become worse. The hyperextension of the knees become dominant, prominent, and the child starts to walk on his toes. The well-known Gower sign might already be present at a very early stage, so already at 1.5 years, we might find this sign of proximal muscle weakness, as you know. Weakness of the gluteal muscles will be also expressed by the way these children walk. We will see a Trendelenburg gait, so we can see a sink of the contralateral side of the stance leg of the pelvis because of weakness of the abductor, so the pelvis will fall down on the opposite side of the stance leg, and in order to ease on the abductor muscles, the trunk will shift to the stance leg side to make it easier to support the trunk while walking. So that's why we will see that the trunk sways back and forth with this waddling gait and Trendelenburg gait, as I said before. These children will typically walk on a wide base, and this is not only because of lack of coordination sometimes or difficulties or because of the weakness, but also because of contracture of the iliotibial band, which will cause an abduction contracture of the hips. Another typical finding in these children is that the stance phase of gait is prolonged, and the swing phase of the contralateral leg is shortened. So this is again an expression of weakness, and we will see a double limb support for a longer time. Now, of course, the observation of pseudo hypertrophy of the calf muscles, which is present in 80% of the patients, and the contracture of the lower extremity of the feet at a much later stage, usually once the patients lose ambulation, in the very typical equinovarus cavus deformation of the foot. Of course, we have to mention the spine. Scoliosis may appear in late childhood or at early adolescence. This finding will usually cause problems in sitting, with having to support the trunk with one arm, which causes other problems using both hands. And not only lift of the trunk to one side, but also hyperkyphosis of the spine becomes prominent because of this scoliosis. So not only in the coronal plane will we see the formation, but also in the sagittal plane with lumbar hyperkyphosis while sitting. Typically, the upper extremities will be less involved than the lower extremities. Usually this will appear 3 to 5 years after the appearance of the lower extremity weakness. We will see a shortening of the elbow flexors, so mainly the biceps, with difficulties in full extension of the elbow, and also weakness of the lumbar, of the shoulder girdle, that will be as seen in the Merion sign, where the child cannot support himself while holding him from the axilla, and very weak abduction of the shoulders is noted. Okay, so the orthopedic management, the goals or objectives that we define in the orthopedic management are mainly to maintain motor function for as long as possible. This can be achieved by minimizing joint contractures in any possible way, maintain straight spine, and of course treat fractures when needed. This can be achieved only by an interdisciplinary team, including physical therapists, occupational therapists, rehabilitation physicians, and so on. I will not go through the whole list. Regarding rehabilitation, I will let our physical therapists to speak of stretching, use of orthosis and adaptive equipment to prevent contractures. I will focus more on the surgical treatment as an orthopedic surgeon. So, proponents for early surgery interventions speak of a very early age for interventions. So usually between 4 to 6 years of age, just before contractures develop, they have shown that early intervention in these ages may delay the need for ambulation may delay the need for braces for ambulation. The need for wheelchair use is delayed, and so they go on and make a list of all all possible surgeries that should be performed again at a very early stage. At the feet level, we speak of Achilles tendon lengthening with tibialis tendon transfer to prevent the inversion of the foot and the equinus of the ankle. For toe clawing, tenotomies of the flexors is recommended. To prevent knee flexion contractions, lengthening of the hamstrings is suggested. Abduction contracture, as mentioned before, can be dealt by lengthening of the iliotibial band. And hip flexion contracture, of course, by release of all hip flexors, including rectus femoris, sartorius, iliopsoas, and so on. So even those who speak of surgical intervention stated that once the patients become non-ambulatory, muscle strength is lost quickly, so we need to prevent these children to get into the non-ambulatory stage, therefore the early interventions. And operations at this time will not reverse the inability to walk, so therefore those who prefer early intervention speak of doing the surgery before the child loses ability to walk. So these recommendations were listed in the Shapiro classification, and please look at the date when these recommendations were published, so in the early 90s. Things, of course, have changed since. Controversies started to rise at the end of the 90s and in the early 21st century. And when patients were asked about the success of this surgery to reach these objectives, as mentioned before, so the answers that the researchers got were somewhat disappointing, and patients who underwent multi-level surgery to prolong ambulation did not believe that results were worth the surgery and all the needed rehabilitation after this surgery, and stated that they would not choose these surgeries again. So people were looking at the reason for the disappointment, and controversies started to be raised and asked regarding the ability of obese children, and we know that in Duchenne many of these patients become obese, to go through rehabilitation, and we know that obesity is a very poor prognostic sign for regaining the ability to ambulate. And also studies have shown that the state of mind is very important for cooperation after these surgeries with rehabilitation, and depression, which is unfortunately common among these patients, may interfere significantly with home exercise programs. Parents' motivation for these surgeries to go through these surgeries is also a factor that needs to be assessed. Unfortunately, we lack randomized controlled trials to compare different therapeutic, conservative, and surgical approaches, but there is definitely a trend from these aggressive surgeries and aggressive approach towards a more conservative approach nowadays. Steroid therapy has made a revolution, of course, as you know, in many other fields as well, also in the orthopedic field. And we know that the steroid therapy, thanks to the steroid therapy, muscle strength is preserved for much longer periods, and therefore there is no need for very early surgical intervention. The muscle function is preserved for longer time. In one of the studies, prednisone was shown to delay the loss of ambulation in patients up to 2 to 5 years. The Flazacort, as you know, has these famous studies from Canada have shown that the decrease in the incidence of scoliosis. So steroids really made a change and made a difference in the surgical approach as well. And these recommendations that I will bring you are based on this task force that was made of experts from all different kind of expertise, including, of course, orthopedic surgery. And when we look at the treatment plans, the recommendations, so you can see that the treatment plan has significantly changed, and the indication for surgeries are much more limited than they used to be before. So nowadays we speak mainly of foot surgery for equinovarus deformity of the feet. This was shown to improve gait in patients with significant ankle contractures, so significant toe walk, but, and this is a very big but that you should take into account, a very good quadriceps and hip extensor strength needs to be there, needs to be present in order to safely elongate the gastrocnemius and prevent the equinus deformities. Anyway, interventions related to the hips and knees are definitely not recommended nowadays, as it has been shown that these surgeries have no contribution whatsoever to improve ambulation. So to the orthopedic surgeons among us, surgeries for lengthening of the Achilles tendon should be done at the zone 1, so to prevent over-lengthening. Lengthening directly of the tendon, as you know, might cause significant weakness, and it has been shown that Achilles tendon lengthening done at a distal level actually shortened the mobilization time of these patients, the ability to walk without braces, and therefore we refrain from doing aggressive lengthening, and if we perform any kind of lengthening, this will be done only at the muscular level, and again with the condition, as I mentioned before, of the patients having a very good quadriceps and hip extensor strength. Unfortunately, this of course excludes many of the patients that we see when they come to us with these equinus deformations. Very often their hip extensors and quadriceps is already very weak, so this excludes the option of surgery to improve ambulation. In non-ambulatory patients, we can discuss correcting positioning of the feet to improve shoe wear. It has been shown that again, Achilles lengthening with tibialis posterior tendon transfers enabled shoe wear for longer time with any kind of shoe wear patients wanted to. But then there are other studies that show that patients, even with significant deformation of their feet, with equinovarus deformation, remained asymptomatic for a long time, even or in spite of the significant deformation of the foot. So the decision to perform surgery on non-ambulatory patients with feet deformation should really be made and according to the family desire, and should be individualized to the specific patient with consultation of the family. Okay, so scoliosis. Scoliosis is of course a completely different issue. Scoliosis will develop in nearly all children who are not treated medically with steroids. We know that conservative treatment with bracing is unfortunately not successful, and progression actually occurs in these patients despite bracing. And actually bracing is not recommended also because it obstructs the respiratory efforts and interferes with pulmonary function. We know that scoliosis has a direct effect on the vital capacity, and for each 10 degrees of scoliosis we can expect a decrease 4% decrease in forced vital capacity in patients. So since progression is guaranteed in untreated patients and pulmonary function will deteriorate as curve worsens, it is really recommended to go on with posterior spinal fusion, which is the only surgical solution for these conditions. So nowadays, surgery is recommended in non-ambulatory patients with a curve which reaches 20 to 30 degrees in a sitting position X-ray. And as long as their forced vital capacity is greater than 40%, otherwise, weaning of ventilation after surgery might become a real problem and might risk their lives. So the goals of posterior spinal fusion is to prevent further progression of the curvature, for one thing, improve sitting tolerance, and of course reduce pain. Some studies have shown that the posterior spinal fusion actually slows down the progression of respiratory decline in Duchenne dystrophy. If the pelvic has obliquity more than 50%, 15%, stabilization into the pelvis is recommended, as shown here in this example. It had been shown that posterior spinal fusion has a positive effect on a number of fields. Function, sitting balance, of course, pain, quality of life were all shown to improve after posterior spinal fusion. Now, steroid treatment had made a tremendous influence on the natural history of the disease. Not only that protocols using the deflazacort showed a significant decrease in the incidence of scoliosis, but also the whole natural history has changed, and progression is not the rule nowadays after being treated with steroids. So the progression might be less predictable, and we don't rush for posterior spinal fusion unless there is an evidence for progression of the scoliosis when we observe two following X-rays before performing any kind of posterior spinal fusion. Last but not least, fractures. Unfortunately, there is a significant increased rate of fractures in Duchenne muscular dystrophy patients. This is one study that showed that 80 children out of 378 sustained at least one fracture, and the majority of these occurred in the femur bones. Of 40% of them occurred in the femur. Almost half of the patients at the time of fracture were ambulatory, and unfortunately 25% of these lost the ability to ambulate after fracture. The reason for fractures, of course, is the low bone mineral density of bones in patients. Even in the ambulatory patients, we know that the bone density is low. Corticosteroids even further decreases the bone mineral density and has a bad influence on the quality of the bone, which becomes even more brittle. Of course, lower extremity weakness is another factor to explain the increased rate of falling and fracturing the bones. So in ambulatory patients, the aggressive management should be the rule, and usually we use the flexible nails for intramedullary fixation immediately once the fracture occurs, so ambulation can be restored as fast as possible. In patients who are non-ambulatory, a more conservative management is advised, so usually splinting is sufficient for bone healing and pain control. So I wish to thank you again for giving me this opportunity to present our experience with muscular dystrophy, orthopedic treatment of muscular dystrophy. And I think it's now time for questions. Thank you very much.